So thank you. Welcome to my next class. So today we are going to be talking about labor assessment as part of the API. So with the labor assessment, with our previous class, we did talk about the antenatal, and we did say that with the API, you as a candidate, you can go and you will be getting either antenatal assessment, either labor assessment, or postnatal assessment. You are not given all the three, or you are not given two. It's just one that you are going to be doing as your API. So today we are going to be talking about the labor API. This is very easy as a midwife. Let's picture something. Let's say that you are working in the delivery suite or in the labor room and a patient comes over. She's feeling abdominal pain, probably backache. She's just feeling uncomfortable, whether she knows what it is or she doesn't know. Once she is coming to the labor room, what is the first thing that comes in mind? Oh, we've got a patient. We've got a patient. Okay, let's lie down. How are you doing? Let's see how, if it's labor. So we tend to do vaginal examination because we want to know how far woman is dilated, to know if it's going to be urgent or not urgent. We do maternal observations. We have a feel of the tummy. We even ask them to go for a wee and we do urinalysis. Those are all the things that we've been doing in our labor room. I want you to picture something. If a patient comes on that first note, probably say she's 4 centimeters or she's 7 centimeters, you'll be like, you can't really tell if she's progressing. It could be that she has been 7 centimeters probably 4 hours ago, but because her first encounter with you are the only person who have done her assessment, so you can't tell whether labor is progressing or not. Do you get my point? So you will have to do a sort of second assessment where you will can tell that, okay, let's say that you have assessed her on the first attempt. 4 hours later, you come back and she's still 7 centimeters. Then you can tell that something is not going right. Baby is not coming down. Labor is not progressing. So then you intervene, you get the obstetricians to come in, they review patients to see if you have to augment labor. That cannot be done in our examination because our sitting for the examination is just 20 minutes. You cannot do an assessment and come back 4 hours later to come and do an assessment before you can make a judgment. So often at times, what is going to be done for you is that a previous assessment has already been done, making it assume like the patient has been seen already. She's already being taken care of, and you as the candidate have been asked to continue care for the patient. So you are now going to do her next assessment and compare with what has already been done by the previous midwife. Do you think labor is progressing? That is the whole thing for the labor assessment. But if they say start work, if they set the timer, what are you going to be doing? So as I always say that in all the assessments, you are doing 3 things within the set time. You are going to be doing the assessment, which is the practicals. Then you will fill out your documentation, which is very important, and you will going to be doing the handover, either to the patient or to the examiner. So let's dive into it. What is the first thing you will want to do when it comes to labor assessment? So the first one you will do is perform your first 6 points of checks. And you remember when I said that first 6 points of checks is doing the approaching scene safety, providing privacy, performing hand hygiene, introducing yourself to the patient, and checking patient's details. Then the last one is you check if mother has any allergy. So there are 6 things you will do on a first. After that, you will want to know what birth patient here. Yes, you know it's a labor, but you are doing it for your assessment. This information is going to be very useful when you are doing your documentation. You are doing a comprehensive assessment. Yes, an assessment has already been done, but the examiner is marking for comprehensive assessment. So assume that no one has taken, do your own checks, have your own data written down. Ask your first three questions. What brought you to us today? When did these things start? And what is your pain score? Or you can just refer to the scenario. Oh, it is stated here that you came this morning with abdominal pain. So she's going to confirm with you. So that's still what brought you here today. When did this abdominal pain start? Then she'll tell you maybe probably 100. Okay, if you are to score your pain from 0 to 3, where 0 is no pain and 3 is maximum level of pain, what is going to be your pain score? Then maybe she says 1 or 2. So 0 to 3 is our midwifery standard for pain score. You probably might have heard 0 to 10. Is it not wrong? But that is for the nurses. We midwives, our pain score ranges from 0 to 3. So you ask her 0 to 3, where 0 is no pain and 3 is maximum level of pain. What is going to be your pain score? I'm so sorry you are going through this. Do you think you will need a pain relief? Yes or no? If she says no, you tell her, you reassure her that throughout your assessments you are going to be doing, if she thinks that, oh, this is getting too uncomfortable, she thinks she needs something to curb the pain down, she should let you know. You get the doctors to see her as soon as possible. However, if she says yes, it doesn't mean you're going to stop your assessment, because you still have a set time to complete. Communicate with her that, let me quickly finish with the assessment, because the doctor will need it to review you and prescribe the right pain relief for you. Is that okay? If you know this, you know that if you're an international midwife from a different country, African country, you know that pain relief, we don't really give it in labor, and we probably might give you paracetamol. But over here in the UK, each stages of labor comes with its kind of pain relief you can take. So a doctor will need to review, or you, the midwife, will need to know how far she has progressed to be able to give her the right pain relief. So I'm sometimes you might not even think that, oh, I cannot even give this. It's not that. It's because of the stages of labor. At certain stages, we don't give certain pain relief. It is not the best. It's not recommended. So that is the whole thing. So you just have to reassure her that, let me quickly finish with the assessment. Once I'm done, we'll get the doctors to review you and prescribe the right pain relief for you. Then you now start with your assessment. But before you start with your assessment, the next thing you need to do is review patient history. Seek consent and review patient history. Reviewing patient history is basically reading the history that has been listed out on your scenario paper for you. So there's going to be a set of history listed out. All you need to do is read it out to the patient and confirm if all those things you have read is correct about the patient. If she has confirmed it, then you can now explain what you are going to be doing. So in our labor assessment, there are 3 to 4 assessments you'll be doing, which is our observation. Then we do our abdominal palpation. Then we are going to do a vaginal examination, because we are coming to assess patient 4 hours later. So we do a VE. Then our final one is urinalysis. You will need all this information to do a very good assessment. And also you are going to need them to fill a very good pathograph. If you don't do these 4, or you don't have 4 of these information at hand, your pathograph is going to be wrong, your assessment is going to be wrong, you are literally going to fail your examination. So the first one is maternal observation. You need to check 6 things: the blood pressure, the pulse, the temperature, the respiration, the capillary refill, and the oxygen saturation. That falls under the maternal observation. After that, we move on to abdominal palpation. Abdominal palpation, this time is going to be 8 things you are checking. When we learned the antenatal assessment and we got to abdominal palpation, there were 10 things we were going to check. But this time we are going to be checking 8 things. It's because labor has progressed to a certain stage. Certain things have already been done. It has taken place. It's not important for you to check. For example, engagement. Engagement has already taken place. The head has even descended. So you cannot check engagement at this point. The next one is cervicofundal height. The head has gone down into the pelvic brim. When you measure from the fundus to the edge of the symphysis pubis, you are going to get a biased result. So cervicofundal height and engagement is out of the picture for now. So what then are we going to check? You have to inspect the abdomen, linea nigra, striae gravidarum, unusual scars you are acquiring, safeguarding, or surgical scars. You now also flex the knees and check presentation. You want to know what is presenting in the maternal pelvis. Then you do your lateral palpation. You want to know the lie, which is the longitudinal axis of the baby in relation to the maternal spine. Then you move on to check for the fetal back position, because that is where you are going to auscultate the fetal heart rate. So you want to know whether the baby is lying on the left lateral or the right lateral. After that, you have a fundal palpation. You want to know what is presented in the fundus. Is it the bum? Is it the limbs of the baby? Then you check for the fetal heart rate. So we'll be using a pinner to auscultate the fetal heart rate. Then after that, we palpate the fundus to check for contraction for 10 minutes. But checking for contraction for 10 minutes is unrealistic. So when you do it, the examiner is going to give you the values. Is that okay? So after you have checked the contraction, you still need to know if baby's movement has been good for the past 24 hours. So Helen, are you happy with your baby's movement for the past 24 hours? Yes. Is that okay? So these are the 8 things we'll be checking for abdominal palpation. Then we move on to vaginal examination. So under the vaginal examination, there are 10 things you'll be checking for vaginal examination. So with the 10 things, let's talk about it. First of all, when you are doing V, you know that the procedure is a sterile procedure. You know that it's a sterile procedure. So what you have to do is you are ensuring that you are wearing your PPEs. So that is your surgical gloves and your apron. Then after that, you check you now are going to check. So you need to lubricate the perineum. You need to seek consent. Let the patient know that is going to feel a bit uncomfortable, but it's not supposed to be painful. If at any point of the assessment she wants you to stop, then you can move ahead and do it. So she wants you to stop, then you just stop. So when you are starting, first of all, what are you seeing at the vulva, the perineum, the vestibule? Is it normal? Is there any structural malformation? Is there abnormal edema? Is there any unusual rash? Or is there mutilation? So if there is mutilation, then there is safeguarding concerns. Then you go in with your 2 fingers. With the VE, you want to know the temperature and the moisture. Often at times they say that if the vagina is hot, you are carrying infection or mother is ill. So you want a warm and moist perineum and vagina. So that's the second thing. Then you move to the station. Back in our countries, people used to say, "Oh, I've done the VE, the head is low, the descent." What is the descent? Yes. What we were checking was station. It wasn't descent. Descent is done abdominally, and descent you want to know the fetal shoulders to the pelvic brim. You want to know the number of fingers accommodating the space. But descent down below is station. However, the definition for station is the descent of the presenting part, which is the head, in relation to the ischial spines. So people tend to use that word descent, which is a verb in that definition, making it look like a noun. So what you are checking down below is not descent, it is station. Station ranges from -3 to +2. If you are within the negatives, -3, -2, -1, you are above the ischial spines. If you are the 0, you are the level of the ischial spines. Even if you are 1 and 2, the baby has come below the ischias, and we will say that the head is low. So we check the station. Then we move on to the cervix. There are 4 things you'll be checking on the cervix. You want to know the position of the cervix. Is it posterior? Is it central? Or is it anterior? After that, how is it dilated? Ranging from 1 to 10. Then you move on to the thickness. So you want to know the thickness and the thinness. That is the effacement. How thin? You know that undilated cervix is as long as 3 centimeters, so very thick. Once the cervix starts dilating, it needs to shrink to become very small. Then we say that, oh, it's thin. Yeah, it's effaced. Then the next one we check is consistency. So you want to know if it's soft, or if it's moderate, or if it's thick. Then those are the 4 things. Then we move on to the membranes. You want to know the membranes. Is it ruptured during your VE? Had it already ruptured? Is it still intact? And is it still bulging? So you want to know about your membranes. Then you move on to the fetal head position. The head in the perineum. What's the position? Often at times people get confused with fetal head position. This is the head. If we are to check the side of the baby, this is how the bones are in alignment. These are the sutures, the lines, and these are the fontanels. So we have the posterior fontanel, we have the anterior fontanel. The anterior fontanel is 2 bones merging together, but they are always together. But it's not just 1 bone, it's 2 bones, but they are merging together. But the posterior fontanel, this one is a bone, just 1 bone. And that's what we call the occiput, and this one comes together, we call it the sinciput. Now, when the head is in the pelvis, okay, let's assume mother's legs is like this. So the head is down below. Oh, that's a good diagram. So the head is down below. When you do your V, you want to know how it's dilated. Okay, that's fine. Now you're going to check the position. You want to know where this posterior fontanel is actually located. Is it up facing this? Is it going this direction? Is it coming this direction? Or is it facing this direction? If this side is facing up, you will say occipital anterior. If it's facing this direction, either left or right, it's occipital transverse. So we have the left occipital transverse and the right occipital transverse. If it's facing down this side, so that means that the baby has turned, and the back, this side, is facing down, and the face up is gone up, then we say occipital posterior. So this is what we need. So you want to know the fetal head position in the pelvis. Is it occipital anterior, occipital posterior, or occipital transverse? That is what we call it. So this is the good position. These ones are all malpositions. This is the best one we want. After you check the position, you also want to know the bones. These 2 bones here, you want to know, are they molding? Are they overriding? If they are overriding, that means they are trying to, the baby is so smart, he's trying to make his or her head small to fit into the pelvis. So if he's trying to override their sutures, this side of the bone, to make it smaller, and this side to also make it smaller, then we will say that molding is taking place. If such a thing happens, sometimes it causes a fluid field in the skin of the baby. It can be a ruptured vessel, which is going to cause a hematoma. But you can't tell a hematoma from a succedaneum, a carpal succedaneum, until baby is born. So what you can actually feel is skin fold bulging. Then you can say caput is forming. Then the next one you want to know is yeah, that is it. So then you are done with your VE, then you come out. Urinalysis, you want to know if there is protein in urine, there is ketones, blood, all those things. Often at time, we are not allowed to do it. It may come in future, but we are not allowed to do it. So that will be provided. Sometimes it will already be stated in your scenario that vaginal examination has already been done. Sorry, not vaginal examination, urinalysis has already been done. So the results is maybe all are normal, something of the sort. So after the urinalysis has been provided, you just need to